Good afternoon, everyone. It's lovely to be with you. I'm Alf Collins here from sunny, hot London, and I've got the door of my office wide open, so you might hear the odd aeroplane and the odd shout from outside. Lovely to be here with you. I'm Alf Collins, I'm National Clinical Director for Personalised Care for NHS England and NHS Improvement. Next slide, please, Gareth. I am not ashamed to tell you that NHS England and Improvement is a bit slow on the subject of PROMs, and what I'm going to be sharing with you during this talk is some insights and some of my experience over many years of working in the Health Foundation, where I was one of the team working on all the person-centred care programmes, but also now 6 years in policy as National Clinical Director for Personalised Care. I'm going to be talking a bit about PROMs, but hopefully I'll give you some extra thinking that will provide, I think, a bit of context with regard to changing the conversation and with regard to shared decision making and high value care. I think the first thing to say is, although NHS England isn't charging forward with PROMs, I personally am absolutely committed to the PROMs agenda. So let's look at this in a broad sense. Healthcare is designed for populations, but it's delivered to individuals. Next slide. And our approach to healthcare is primarily disease or condition centric. It's what it is. That's the way it is. It's not primarily person centric, and I'm going to use personalised, because that's what we're calling person-centred care in England right now, as my preferred term during this talk. So we're not as personalised as we could be, despite the fact that healthcare is provided for individuals. Next slide, please. And those are just inescapable facts, but they lead to predictable and very often unfortunate consequences. Next slide. I don't know what comes to mind when you look at that slide, but here's a woman in her 80s, living with multiple long-term conditions, living with the impact of those long-term conditions, and also living with the burden, and I will use that term advisedly here, of hospital appointments, diagnostic tests, changes in lifestyle, and pills and operations and injections. Next slide, please. The so-called burden of treatment. And for those of you who don't know about burden of treatment literature, do go and look at it. Do look at it. What we know is if we live with 3 or more long-term conditions, then the NHS invites us to spend 3 or 4 days a month paying attention to those conditions, waiting for diagnostic tests, waiting in outpatients for repeat visits, etc., etc., etc. If only we had personalised or person-centred conversations with people about whether it's right to add yet another treatment. If only we had conversations with people about what are their goals, what are the outcomes that they'd like to think of from those treatments. And here's what the outcomes could be in terms of your preferences, what matters to you, if only we could do that. And although Wales, I think, is really, I guess, leading internationally in this space, many of us are struggling to keep up. But I guess in England, what we're trying to do is come at the what matters to you agenda from a slightly different place. And I'm going to be sharing some of that thinking with you today. Next slide, please. So we have a real problem and a predictable problem with over-treatment when it comes to the burden of treatment and people living with multiple long-term conditions, over-medicalisation. But look at this. There's an amazing map. It doesn't have Scotland on it, doesn't have Wales on it, does it? But I am coming from the English NHS, so please forgive me. Public Health England in 2019 was invited by the Secretary of State to do a review of the prescriptions of 5 classes of dependence-forming medicines in England in 2019. And it was found that 25% of the adult population of England was on one or more dependence-forming medicines. And that rose to 30% in the most deprived areas of our country, 3 in 10 people on one or more dependence-forming medications. These are essentially medicines for anxiety and depression and or long-term pain and or insomnia. And there's a map on the right of just one of those classes of drugs, opioids, strong opioids, and the mapping of high prescription rates of opioids absolutely maps onto the most deprived areas of our population. This is a scandal. This is an absolute scandal. If people with anxiety and depression, chronic pain and insomnia thought about what really mattered to them, thought about their goals in their life, were encouraged to do so, and understood the benefits and harms of the available courses of action for them, it's almost certain that we would not have this problem. Next slide, please. On the other hand, in England, we've got 5.5 million people with undiagnosed hypertension. We've got many millions of people with hypertension that aren't taking their pills. We know that people who live with long-term conditions, only about 50% of them adhere to medication regimes as prescribed. Next slide, please. So medication adherence is a really big problem as well. 78% of adolescents with asthma don't take their medicines as prescribed. And yet 1,400 people a year die with asthma in England. This is a scandal. This is an absolute scandal. On the one hand, we're over-treating people. On the other hand, we're under-treating people. Next slide, please. And there's a kind of an overview of one particular operation, because I've been talking about unwarranted variation, over-treatment and under-treatment. On the left is the number of, the y-axis is the number of hip replacements per 100,000 people over the age of 65. This is weighted, and all of these scales here are CCGs in England, and there's a 5-fold variation in hip replacement rates. Next slide, please. And whatever treatment I looked at, I could show you this. This is hip replacement rates, actually from 1991. It's got worse since then, and hip replacement rates go down from least deprived to most deprived. So there's a massive inequalities gap here. So we've got big problems with over-treatment, we've got big problems with under-treatment, we've got big problems with variation, and most of that variation means that people in the least deprived areas get the least appropriate treatments. It's a national scandal. Next slide, please. So why are we in this mess? Why are we in this mess when we know that high value care, next slide, is about the application of evidence-based medicine. It's a coming together of best available evidence, clinical expertise, and individual patient characteristics and preferences. That's on the left-hand side of the screen. Look at the right-hand side of the screen. So it's the methodical application of population-based evidence. But what evidence? At the moment, as you'll know, we tend to use clinical outcome data, surrogate markers of success. We don't do enough to use PROMs data in clinical trials. So the evidence that we use in terms of building our NHS, certainly in England, is arguably not quite the right evidence. But what we're trying to do with evidence-based practice is apply methodically population-based evidence to individual clinical characteristics and personal preferences. And the purpose of that is to improve the quality of decision-making. It's at times that decisions are made that leads to where money is spent. If we've got the highest possible decision quality, that will lead to high value care and reductions in unwarranted variation. So it's a coming together of, to my mind, clinical and PROMs informed evidence, individual clinical characteristics and personal preferences. Next slide, please. So we know what we should be doing, but we don't really do it. We really don't do it. First of all, the evidence question. Bluntly, we don't understand it. As clinicians, there's too much evidence out there and there's too much contradictory evidence. Tammy Hoffman and Chris Del Mar, Chris has just sadly died, in Australia did an international systematic review in January 2015 that showed that patients overestimate the benefits of treatments, pretty much any treatment, and underestimate the harms. They then in 2017, there were 2 years between those two papers, they did the same systematic review, but they changed just one word. And clinicians are the same as patients. Clinicians tend to overestimate the benefits of treatments and underestimate the harms. There's a whole series of reasons for that, not just the Daily Express, but mostly the Daily Express. No, sorry, I jest. Next slide, please. And bluntly, we don't share decisions, or we're not as good at it as we think we are. There's a wonderful paper by a friend and colleague, Caroline Cupit from Oxford. A PhD was looking at the kind of internal processes that GPs in particular go through when they're sharing decisions with patients about appropriate courses of action. And the bottom line is clinicians are driven to decision making in terms of improved clinical outcomes, not necessarily in terms of outcomes that matter to individuals, by well-intentioned national policy and strict adherence to single disease guidelines. I've got a slide about this coming up next. Clinicians rarely seek patients' preferences or the outcomes that matter to patients. It's rare. So most decision making is indeed physician centric. And actually patient involvement in decision making is often confined with them saying, no, I don't want that, no, I don't want that, no, that's not for me, rather than, oh, that's interesting, I've heard about it, why can we discuss that? So it's rather passive in terms of patient involvement. They tend to say no to stuff that clinicians think they should have, broadly speaking. It's a wonderful paper there from Chris Tarrick. Next slide, please. So a core tension is that, on the one hand, clinicians are being told things like offer everyone with a Q-risk score of more than 10% a statin, and on the other hand, pay attention to what matters to patients. And what tends to happen is that clinicians do what their system wants them to do, which is offering everybody with a Q-risk score of more than 10% a statin. That's what they do. But wouldn't it be fantastic if they really did more of paying attention to what matters to patients? And that's, of course, what PROMs is all about, and it's what shared decision making is all about. For the rest of this talk, I'm going to start to talk about how I think shared decision making and the use of PROMs can start to come together. Next page, please. Next slide. So shared decision making is a big part of the answer. It's a focus on bringing together the evidence, as I say, albeit that currently it's faulty. It doesn't pay enough attention to what matters to patients. But it brings together evidence and individual patient goals, values, and preferences. That's what shared decision making is designed to do, albeit that we don't do it as well as we'd like to think we do. Next slide, please. I just want to reinforce, this is from the shared decision making literature, that if we really just pay attention to clinical outcomes, then we don't pay enough attention to what really does matter to patients. This is a wonderful slide from Karen Sapuka, a colleague at the Massachusetts General Hospital in the States. And this is just about a breast cancer decision, just about, it's a pretty big decision now. And these are the preferences that patients, that really matter to patients. So doctors think that 71% of women want to keep their breast. It's only 7% of informed patients that want to keep their breast. Virtually every doctor, 96%, thinks that women with breast cancer want to live as long as possible. Actually, it's only 59%. 80% of clinicians feel that patients want to look natural without clothes. It's only a third of women, and so on and so on and so on. You're not going to pick these really important preferences up unless you ask women about them. And of course, clinical outcome measures don't do that. I think even more starkly, next slide, please. And this comes from Ray Fitzpatrick's work, primarily on the long-term conditions from the LTCQ. The LTCQ has got 20 items in it, 19 of them are non-clinical. So as clinicians, we tend to ask people living with long-term conditions about their condition, or their conditions. And our language is kind of strewn with words like diabetes and arthritis and COPD and depression, and quite rightly, that's important. What patients want to talk about, the word cloud on the left, is very, very different. It's not the condition itself or necessarily the management of the condition itself, it's the impact that the condition has on their psychosocial functioning. So the words they want to kind of bring to the conversations are words like fear, grief, frustration, guilt, loss, stigma. If you haven't seen the LTCQ, I think it's a fascinating PROM, because it does bring out all of these elements of impact of long-term condition, not necessarily long-term condition itself. Next slide, please. So, we know that informed patients and clinicians have got very different perspectives and preferences. So what are we doing? What are we doing? We've constructed a health system, I often describe it as a parallel world that's there to deliver on clinical outcomes. I don't think that's wrong. Many clinical outcomes are really, really important. However, we're not doing enough at all to pay attention to what matters to individual patients. Next slide, please. So PROMs are part of the answer. They're a big, big part of the answer. They really are. It's how to bring together shared decision making and PROMs. And I'm going to share with you our thinking in NHS England over the next few slides before coming on to, towards the end of this talk, some more visionary slides about what the future might look like. So next slide, please. So the overall goal surely should be the Goldilocks principle, just the right amount of healthcare for both individuals and for populations. Not too much and not too little. And at an individual level, that really, really, really matters. And it really matters for people all the time, but it particularly matters for people living with long-term conditions and multiple long-term conditions, where the burden of treatment can be profound. Next slide, please. So part of our role is reducing and managing unwarranted variation. I showed you a couple of slides about that, and I'm going to go back to them now. Next slide, please. So here's a thought. What's the right hip surgery rate for the population segment of people over the age of 65 with hip pain? How many hip surgeries should we buy? Yeah, difficult, isn't it? It's really difficult. Currently, what we do is we buy the number of hip surgeries that demand shows us we should be buying. But demand currently is not truly informed demand. Only 6 people in 10 presenting for surgery in this country have made a truly informed decision about whether it's the right course of action for them. So demand at the moment is uninformed. So we need to move towards informed demand, both at an individual level and at the level of a population. Next slide, please. So we need to get to a point of optimality where we're not doing too little stuff and we're not doing too much stuff. This is what Muir Gray talks of as the most important slide in healthcare. So if you think of any condition, like COVID, right, is a good example. If you look at the green line, then the green line, the bottom left would be things like masks and social distancing. Quite high up the curve on the left-hand side of that curve. Masks, social distancing, all that sort of stuff. As you get up that curve, you start to move into things like steroids. You then move into stuff like oxygen masks in hospital, and then ventilation, and then possibly ECMO, extracorporeal membrane oxygenation. So the benefits are starting to plateau and the harms are going up as you do more and more and more at a population level. There is a point of optimality, both for individuals and for populations, where it's just the right amount of healthcare, just the right amount of healthcare. And that's what shared decision making is all about. Next page, please. Sorry, next slide. But in order to make sure that we construct services according to informed demand, we need to make sure that we match care, support and treatment to both clinical characteristics and personal preferences. At the moment, most of our stuff is to do with clinical characteristics, not enough to do with personal preferences. That's why PROMs and shared decision making are important. Next slide, please. So shared decision making is about providing healthcare at the point of optimality for individuals and populations. Clinicians share with people their diagnosis and the evidence-based options and what's known as the benefits, harms, consequences and burdens of those options. And patients, through the shared decision making process, start to talk about what matters to them, their circumstances, their values, their preferences. What that leads to is improved decision quality, and that leads to high value care and informed demand on the system, so that all decisions accord with the evidence, clinical characteristics and personal preferences. Now, in order to have those conversations, we need to make sure that teams are trained to have the conversations. We need to make sure that patients are prepared and the system is supported. You can prepare patients by giving them a PROM beforehand. That can help inform the conversation and move the conversation in the right direction. The place that we've moved to in England to start this process of bringing together shared decision making and PROMs is we're using decision support tools, and I'm going to, in the next few slides, share with you some decision support tools. Next slide, please. It is all about what matters to you. The PROMs agenda and the shared decision making agenda are designed to bring out patient preferences in terms of the outcomes that matter to them. There is a point of convergence. Our starting place in England is different in policy terms. There are islands of great practice in terms of using PROMs in England. In policy terms, we're in a slightly different place to Wales. Next slide, please. So, decision support tool, that could be a PROM, plus decision counselling equals shared decision making. Next slide, please. Our decision support tools look like this. And this is part of the tool for people with cataracts. And it's just a simple decision to be made. Do I want to continue with either doing nothing or aids and adaptations, or do I want cataract surgery? 3 choices. And here, prior to the consultation, they're encouraged to talk about their preferences, what matters to them. Now, this is where I see PROMs and shared decision making or decision support tools coming together. The what's important to you element of this conversation. Next slide, please. This is what we're encouraging as of 2 weeks' time. These are about to be published in this country. Clinicians to focus on in their conversations. So these are the 2 options: using aids or adaptations and cataract surgery. And these graphs talk you through the benefits and harms of each. So we are moving forward with these decision support tools in England, and we're incorporating PROMs type data into them, but they are not as good as they could be because they need to incorporate fabulous PROMs data. And that's the next step for us. And I'll show you what I think we should be doing over the next few slides before I finish. What I think we should be doing in England is bringing together so-called clinical decision support and shared decision making to develop a true learning health system. And I wanted to share these ideas with you as people are primarily interested in PROMs, because it might spark some ideas from you. Next slide, please. Here is a clinical decision support and shared decision making tool that has been developed at the University of Cambridge by the Winton Centre for Risk Communication. It's called Predict. Do have a look at it. Put Winton Centre Predict into Google and have a look at it. What it's for, this particular one, is for people with breast cancer. And what it does is really rather wonderful, because rather than just looking at all the evidence-based data for whole populations of people with breast cancer, the first part of the tool, you put demographic data into the tool, and then it's got a really, really clever algorithm behind it. And what it does is it segments the population according to that data and provides more personalised information for patients and clinicians to look at to share a decision about the right course of action. So next slide, please. So what it's doing is it's taking the evidence base as it currently is. And as I say, we need to build PROMs into that evidence base. And what it's doing is it's pre-populating a decision support system. So you put into the decision support system, next slide please, the individual clinical characteristics. And you're then segmenting the population of people with breast cancer according to individual clinical characteristics, because we know if you've got metastases, you've got a higher chance of getting better results from chemotherapy, etc. But all of this is done before you share a decision with the patient, because the algorithm does lots of clever stuff, and it then presents to the clinician and the patient the options in terms of moving forward, which are quite personalised actually. Next slide, please. The patient then looks at those options with the support of the clinician. If you just press next slide, and together they can decide on the best course of action in that particular set of circumstances. The idea being that you get improved decision quality, decision based on evidence, individual clinical characteristics, and individual preferences. Now, wouldn't it be amazing if rather than evidence-based information from randomized controlled trials based on clinical outcomes, what came into this engine was PROMs data as well? And wouldn't it be great if that engine could use PROMs data that was being generated as a result of these decisions that are being made here? Next slide, please. In other words, a true learning health system, so that you've got continuous updating of the decision support system with real world data. So you're looking not just at clinical outcomes, but PROMs as well for this particular population of women. And the system, the algorithm in the background, is doing a heap of learning for you based on a continuous update from data from every single patient. Next slide, please. Is that just dreams? Well, it's all doable. Most of it, in fact, all of it is being done somewhere already. The challenge, I think, is for us to bring all of this together. I'm not saying a digital support system is the only game in town, but we do need to bring together shared decision making, the use of PROMs, both in research and in real world conversations. And we need to do it for every patient, every time, everywhere. That's me. Thank you so much for listening. I hope I challenged you. I hope I gave you some different ideas at the end of the conference. I didn't focus entirely on PROMs, and I do hope that it was of some help in sparking some ideas for you for the future. Thank you so much for your time. And I think, Sarah, if I have a look at the chat, I forgot to ask you at the beginning for your questions, but I'm told that in the chat there will be questions, and I've just opened up the chat. Oh, it's spinning around. I think it's about to give me some questions on the topic. So I've got a question from Tim Hugenboom on the topic of point of optimality. This point will differ per patient, with some considering certain levels of harm to be less relevant. Yeah, absolutely right. How could we navigate this on a national level? Is this where the NICE sets limits to care provision? Tim, I think it's a really important point, and I think part of the answer is about that relationship between clinical decision support, which is about clinical characteristics, and then shared decision making, which builds on clinical decision support, which builds in patient preferences. So to take a hip replacement as an example, you wouldn't do a hip replacement on somebody who's got minimal or virtually no osteoarthritis. So there's something for me about clinical thresholds that's important there, and that's where I guess NICE really comes in. but over and above clinical thresholds, there's these individual patient preferences. Anna T says this makes complete sense. Well, I'm glad it made sense. I'm really pleased it made sense. However, I'm reflecting on the understanding that so much of this is impacted by culture, custom and practice, and maybe our biggest challenge. Yeah, right. I mean, yeah, the way we do things around here, right? And there is something for me about the clinical model and clinical outcomes and clinical decision support systems. You know, I've only got into CDS over the last couple of years. It's all about the clinician making decisions based on data and clinical data, and it's a huge cultural shift. I absolutely believe that PROMs are one of the golden keys to bring about this shift, to change the conversation. You know, what I would say again is that you've got to change the system, supportive system. You've got to train teams to have these conversations. So, for instance, this thing, negotiated agenda setting. My background is communication skills training. Negotiated agenda setting, it's the way that clinicians start a conversation. So, good morning, Mrs. Smith. I'm Dr. So-and-so. It's lovely to see you. My understanding is that we're here today to talk about, is that right? Is that your understanding? So I wonder if you could tell me what your priorities are for today's time together. Now, we would love to think that clinicians do that all the time, putting patient priorities first and patient preferences first. It's really difficult to do, actually, as a clinician, especially if you're half an hour behind. Really, really, really challenging. So we do need, I think, a significant set of training programs. Those training programs, we're doing it in England, can help people understand, oh, I'm not doing this, I'm not doing it as well as I thought I was, actually, and Mrs. Smith's preferences really do matter. They're really important. So yeah, the big shift, I think, is cultural. I've got an anonymous. Do you think the PROM focus is something that needs to align to condition-specific pathways, or PROMs focusing on what patients want? Sometimes that's a different. Oh, it's so cool. Isn't that a lovely question? I guess after, I'm old, I'm in my 60s. You know, I was trying to be a revolutionary 25 years ago. It doesn't work, does it, in healthcare? So there's something about going with the grain, it feels to me. There's something about starting. This is about a shift in clinical attitudes, mindsets and behaviours. You've got to start where people are. You know, where clinicians are is you know, they're kind of steeped in the disease-centric, condition-centric model of care. So yeah, I'd love to get to a place where PROMs are about a non-condition specific. They're about, you know, my life. But I think that's a few years hence. I think we have to start where clinicians currently are and help gain kind of traction in that way. What a great question. Lots of anonymous questions. How do these processes differ for patients with reduced capacity for decision making? So the processes I'm talking about, so the training I've been involved in, we've set up this organisation called the Personalised Care Institute. All of our training focuses on working very closely with people with who are at the lowest quartile for health literacy. And part of our work as clinicians should be to understand people's level of health literacy, to understand people's level of capacity. Do have a look at the GMC informed decision making consent guidance for more on that. You know, we need to assume that people actually do have capacity. They may well not have high levels of health literacy, but lots of really good stuff on that in the GMC informed decision making. Tim Benson, yeah, lovely to see you, Tim. Thank you, great work you're doing. Most SDM tools focus on clinicians. We need to ask the patient. I'm going to challenge that. What we're doing in England is we're producing what we're calling decision support tools. In other words, they're tools for patients and clinicians. And that what we want them to do is to be sent out. We're going to put them on the NHS app, is that patients will have them before a consultation, but they're also the core piece of them, middle 2 pages, are for use within the consultation. And the reason I think they're for clinicians and patients is that, you know, remember that those 2 Hoffman systematic reviews, patients and clinicians don't understand the benefits and harms of the options. So yeah, absolutely. Our tools are designed for the dyad, the clinician-patient dyad, but also for use by patients pre and post consultation. And you're right, Tim, we also need to link it into systems, so these are all available at the point of care, and it really, really isn't easy. Tim Hogan Boom. God, this is nice, isn't it? I wish we were in the same room. Wouldn't it be good? Or we were going out for a beer after this. That would be great. Is it perhaps also time to beginning training patients? Yeah, it's cool, isn't it? So we're working with the Patients Association on all of this stuff. And I think we need to, oh God, I was going to use a policy phrase. I can't think of another one. That, you know, turn the dial on this. Isn't that awful? Policy, sorry. But we need to do more on this, don't we? You know, we are going to be getting these decision support tools onto the NHS app. That's not as easy as you like to think it was. But, you know, I think there's a lot that can be done. Or they also go on the big charity website. So our I ones are going onto the RNIB website, etc., etc. So we're doing lots of stuff to kind of encourage, support the population to get on board. But hey, Tim, we could do so much more, so much more. Yeah, interested in people's ideas on that. Help. Wales, what are you doing? Help. We should collaborate a lot more, shouldn't we? Carl Lander, how can we help patients drive improvements in PROMs collection and usage? Yeah, it's an interesting one, isn't it? There's something about how engaged are people in managing their own health. I did quite a lot of research 20, 25 years ago on this, and Angela Coulter's done a lot of research on this. You'll know that perhaps the data from the patient activation data, 4 people in 10 living with long-term conditions don't want to think about their health at all. I mean, well, when you start to look at that, that's scary, isn't it? So why would they, you know, why would they fill in PROMs? Why would they collect PROMs? Why would they do that? So there's something for me about really gentle, sensitive conversations with people. Perhaps even, I'm thinking about working with people at activation level 1, hateful phrase, people with low levels of knowledge, skills and confidence to manage their health. You know, it's something about approaching it obtusely. It's something about, actually quite a lot of the work we did years ago in the Health Foundation was supporting people to set themselves goals that they didn't think would anything whatsoever to do with their health, you know. So, you know, what's important to you? What are you missing out on at the moment? What do you think you'd like to do differently? What have you considered? What ideas do you have? Have you spoken with others? So helping people to start to understand that they do have some sort of agency in their lives, and then over time helping them transfer that agentic perspective, that sense of agency, onto other more health-related elements of the way they live their lives. So, oh, that was a pretty meandering answer, wasn't it, Carl, to a question, but I hope it's kind of helped spark some other ideas. That knowledge that 4 in 10 people living with long-term conditions have got low levels of knowledge, skills and confidence to the degree that they don't even want to think about their health. I think that helps us conceptualise health and the provision of healthcare in very different ways. Anonymous. There's lots of anonymous people. I wonder if the anonymous person is one person or lots of different people. Whoever you are, you don't want to be known, but that's okay. Is there a national list of PROMs to use for what conditions in England? I understand it's a minefield in one specific condition. If no, should there be one? Right, I'm going to let you into a secret here. I was on the National PROMs board for 4 years in England, up till about 2016-17, where we were pretty proud. We had 4 national PROMs. We thought we were doing really good stuff. As many of you will know on this call, there's lots of islands of good practice in this country. And well, frankly, we don't have a national PROM strategy, right? It's going to be really open with you. It's not for want of trying. is not fond of trying. So as I think you can probably tell from this talk, I'm coming at it from a slightly different direction, which is that there appears to be a real appetite for shared decision making in England, and you just can't do shared decision making right if you don't populate your decision support tools with PROMs data. That's the bottom line. That's the bottom line. So that's the way I'm coming at it in England. Help me. If anybody on the call who wants to help me, alf.collins@nhs.net. There's lots of us working on it. We do think we should have a national PROMs strategy. I've had 2 passes at the board in NHS England to get it going. I just need to gather a bit of energy and momentum and try again in the next year or two. alf.collins@nhs.net if you want to help me. Blimey, I've talked a lot, haven't I? And I think we've run out of questions, and I'm 3 minutes early. So I reckon, unless there's any urgent questions, I'll give you 5 seconds. 1, 2, 3, 4, 5. I'll hand over to Sally Lewis. Is that all right? Thanks, everyone. Sally, over to you.
Hi, Alf.